discuss with us today. So let's welcome Dr. Bernadette Grosjean, and we'll give the forum to you.
Thank you so much, Mike. I'm not going to speak so much about neurodivergent doctors today, but that's certainly a subject I'm happy to come back and do that another time. So your usual, I don't have any conflict of interest. I have been indeed consultant for a certain number of groups looking to autism. This lecture is for educational purpose, and here's what my goal is today: to help you to have a better understanding of a new language for many of us, the language of neurodiversity. After all, many of us were trained where autism was not even a category in terms for adults. I want you to be more familiar with particularities presented by autistic adults that you have in your practice, you may not know yet, and have a better ability to identify them and recognize them, because it's important when you work with someone, of course, to know how they function inside. I want to help you to make differential diagnosis, improve communication. So this is a lot, so an ambitious program, but hopefully we'll do this in the coming hour. So my talk today is about autistic adults without major intellectual disability, which is very important. These are adults that you are all seeing in your practice, whatever the practice. By doing this, I'm not, of course, in any way trying to minimize or deny the particular struggles and pain experienced by many autistic children, adults, and their families when autism is associated with multiple and severe intellectual disability and physical abilities. The majority of these autistic men and women are the ones who kind of are the face of autism for many of us. They have high needs and often require intensive support during their entire life. My talk today is about a different part of the iceberg, of the autistic iceberg. One part of that iceberg emerged between 1994 and 2013, thanks to Lorna Wing, when she coined the term Asperger after she reread Asperger and identified a different kind of phenotype of autism than the one of Canners, that the one was known until there. It still was mostly speaking about boy and men. Since the beginning of this century, a combination of new research and social media activism created literally a sea change in terms of identification of autistic people who until then were mostly unseen and undiagnosed. For the majority, for the majority of them, in particular for women, being autistic was having an invisible difference. They did not look autistic enough, often because they had learned for decades to mask their autistic traits, but that's not without a heavy psychological price to say, as we will see. Being able to mask and pretend to be normal does not mean that the person does not need support. And to get support, you need to be seen. And that's what we're going to try to do today. So let's start by listening Mrs. Groomer, the mother of a young autistic man, in the 2002 documentary Refrigerator Mothers.
When Stephen was not even 2 years old, I was at the library, and the librarian said something about, we have some books here. Would you like to read something on autism? You know, autism. The little things, according to this book, seem to identify with Stephen. The rigidity, the repetitiveness. Because next time I was at the doctor's office, I asked if he thought Stephen had autism. And it was more than one doctor at that time. It was a team of them over at the University of Illinois. And they said no, that it may be an emotion disturbance, but it's not autism. We did not fit the mold. We did not fit the classic mold for autism, which is white, upper middle class, and very, very bright.
Jimmy is an autistic child, 11 years old. His father is a specialist in nuclear power plants.
here your child has a disability that you recognize. And they said, no, you can't be that. You can't even be a refrigerator mother.
So don't be that doctor. Every day, autistic children and adults are told that they cannot be autistic because they do not look autistic, which is kind of weird for a doctor to say. They do not look autistic because they are old, they are women, they are part of minorities, because they make eye contact, they have a sense of humor, empathy, sometimes they have a job, they have a family. But autism is much more than the old stereotype. Being autistic means having a different neurobiology, which influences how someone perceives, experiences, processes, interprets, and reacts to the world. You see autistic people every day. We know that they represent 2% of the population. They are your patients, your co-workers, your friends, and maybe some family members. But generally, few of you are aware of the autism thing. And that's fine in regular life. The person you love, you like or dislike is just that, the person you love, like or dislike. But if the psychiatrist is not able to identify an autistic person behind her or his psychiatric symptoms, that increases the risk of inappropriate diagnosis and inadequate or delayed treatment.
When Steve
On the other hand, being able to recognize an autistic neurology entangled with complex, often atypical psychiatric and medical symptoms can be the source of great relief for both our patients and ourselves, and it will greatly improve our chances of being able to work together with our patients in a fruitful way and avoid many, many misunderstandings. Today, I want to share with you tools to help you in that task. The surgeon has blades. We have a sense of observation, or ability to ask questions and to listen. I will give you means to better understand what's happening inside the person, so you can better understand what you see or do not see at the surface. Stereotypes are hard to change, especially in medicine. So let's take some of them directly and look at them. Autism is not an illness that can be cured. Autism is a neurodevelopmental disorder, condition, or difference. Autistic children do not grow out of their autism. They grow up to be autistic adults and they die autistic. Autism is not rare, as I said, 2% of the population. It's present in every age, race, religion, class, culture, profession, and there's an overrepresentation in the LGBTQ population. The male-female ratio is 3-for-1 or maybe 2-for-1, no longer the 10-for-1 we talked of 10 decades ago. And I would say if you just remember these slides from that talk, I hope you remember more, but this is important. Autistic people have emotions, they have empathy, they feel pain, even if they may experience and express these things in very different ways that you may expect. So, as I said, autistic people are in your clinic, in the ER, in the field. In fact, a recent Swedish study was estimating the prevalence of ASD, so autism spectrum disorder as they diagnose it there, in the population of new patients at almost 20%. Now, a lot of people have contested this number, but think of it if it's 10% of the clinic. How many people we see who are autistic, and we don't know. 80% of them have psychiatric problem, 60% suicidal ideation. Actually, suicide is the second leading cause of death in autistic adult. Second cause, it's the 10th for the general population. And the life expectancy of autistic people is 15 years shorter than the rest of the population, which is enormous. One of the reasons we explain that is because autistic people perceive and express pain differently. They may have pain, they may not be able to identify it properly, and then when they communicate to healthcare professionals, their face, their tone may not be the same as what someone else would express. So they're not always taken seriously. They're sent back home and sometimes decide never to come back to the hospital. Another problem, it's even in particular if they're high functioning, in quote, we will see why we want to change that word. People who are brilliant in their profession may have terrible difficulties making a phone call, filling a paperwork, and that again can compromise the care. So you hear me use a lot the word autistic person, and I'm sure you've used, and many of us have been used to hear the right thing is to speak about a person with autism. So why would you say an autistic person? Well, when you say someone with autism, it implies that the autism is something, the autism is something you can remove from the person. We cannot do that. We cannot remove autism from someone, no more that we can remove gayness from someone or tallness from someone. And it's why the majority of autistic people prefer using that identity-first language. You've also heard a lot about neurodiversity. What is that? Well, neurodiversity came a little bit in contrast with the way the medical profession tends to speak about people and define people in terms of deficit and illness and see differences essentially as illness. Remember, not far ago, that's how homosexuality was seen. So neurodiversity considered that we all have different brains and we're part of this neurodiversity, like biodiversity. Now, the people whose brain is similar to the majority of their fellow human beings are called neurotypical, and the minorities are called neurodivergent. We think that 10% of the population is neurodivergent. It's not just autistic people. It's also people who have ADHD, who are ADHD, have dyslexia, dyscalculia, dysgraphia, even left-handedness. If you think of it, these are different forms of brain. The neurology is slightly different, and you have a lot of these things together in general and so on. Now, I mentioned high functioning, and that's also something that the neurodiversity advocate want to change that terminology. Why is that? In the model of disability, we consider that the disability is not solely the result of one person's characteristics, but it's the result of the interaction between one person and the environment, as you can see on the picture here, right? Depending on what the type of support you have, you may be able or not to watch that soccer game. So in that context, neurodiversity advocates think that using the term low functioning or severe or high functioning are not necessarily appropriate. One problem is when you speak about low functioning or severe, we may dismiss all the abilities of a person, all of them. We may give up the idea of progress, which is a big issue in particular in autism, right? If you see Temple Grandin, that I suppose you all know, big autism advocate. Well, when she was 2, Temple Grandin, the doctor considered she was brain damaged and recommend the parents to send her in an institution and forget about her. If the parents had pursued that, well, we would not have been heard about Temple Grandin. So the notion of being aware of how much need someone needs or little need is very important. It's a different way to define people. Same with high functioning, which is also misleading. High functioning doesn't need the person doesn't need support, or the fact that she's masking and try to look normal in quote and fit in the environment means that sometimes at the price of a great cost in terms of physical and emotional energy. So neurodiversity advocates use the term, we need high support need or low support need. So let's go to how do we define autism today? So 2 sentences here that I think are very important. It's a word attempting to describe millions of different stories. And another sentence well known is when you've met an autistic person, you've met an autistic person. Even if it's 2% of the population, it still represents millions and millions of us. And different, not less. That's extremely important, as Temple Grandin brought. Now, globally, it's highly heterogeneous condition, genetically and phenotypically. Being autistic affects how you feel, learn, process information, communicate, behave, and interact. And we will see that you have difference in terms of cognition, perception, and neurology in general. Now, what about the DSM? Of course, I'm speaking to psychiatrists, right? So I say, well, what's the DSM saying? And don't get me wrong, I suppose some residents are listening to me today. You need the DSM, you need to know the DSM to pass your board, you need to read the DSM because it's interesting, we'll give you some ideas. You need the DSM because that's how you get paid and your patients are reimbursed. But of course, there are a lot of issues with the DSM, which can be generally considered, it was after all a tool for research. It's not necessarily a fully useful clinical tool. And another big problem of the DSM is that is looking at individual essentially in terms of deficit. And it is particularly notable with autism. So it's important to look at things we have problem with, but when it's the only way to define someone, and you see here what deficit, failure, these are like in the first paragraph, looking at autism. So of course, when you tell someone, you know, you're autistic or your child is autistic, and they look only as a perspective of deficit, this is a catastrophe. It's very scary. Same here, the way things are said, and I say words are important, it's also particular to the DSM. And it's not just for autism, of course, the DSM has been criticized for many reasons that could take a couple of other grand runs. And the DSM is not the only way to make a diagnosis. You see today with the tools I will give, and I want to give here another perspective about what are characteristics of people who are autistic. Not just autistic people, for instance, people with very high IQ can also have some of the without autism can also have some of these characteristics. But you can see that we can look, can you speak with a patient when discuss with them, and you can also notice some of these characteristics in terms of integrity, creativity, expertise. Yes, they may have repetitive behavior and other things like that, but you want to look at what's positive too when you make that diagnosis. So there is a problem with the deficit narrative. It's been said for a long time. Stephen Hyman criticized the DSM, saying it's kind of an epistemic prison. And I fear sometimes when I see young people who are trained with the DSM and who fear they cannot think out of the DSM, please do. You will not. We see a lot of patients that don't necessarily fit the square in which we want to put them. But it's an issue. A lot, as I said, the benefits, the money, the treatment are given to people depending of a DSM diagnosis. So a lot of parents are very concerned that questioning autism as systematically a disease and an illness, as it is done in the disorders, it is done in the DSM, may deprive them and their children of support, and it's a legitimate concern. So this is a big debate in the community. If any of you is on Twitter and Instagram, and look at there are a lot of discussion there. So let's look at a little more classic view of what we have when you speak about autism. Genetics, it is genetics. Genetics is extremely important. It's not only genetics, but as you see, heritability is 80%. Monozygotic twins between 70 and 90% of co-occurrences. So genetics is there. It's multiple and hundreds of genes are at play. Only 5 or 10% of autistic patients have more what we call a monogenic syndrome. We can more identify Fragile X, tuberous sclerosis, and they are again often the face of autism. The children you'll see often, and we more automatically think of autism when we see them. There are a lot of co-occurring conditions. We will speak about that times and again. That can intensify the traits of autism or mask some of them. And I like the word they call genetic hitchhikers. And of course, the environment play a role too, in particularly epigenetic modulators that can increase some traits or hide them. In terms of neurobiology, so we are speaking about something that really exists. Sometimes people say, well, what do you have proof of what you're saying? Yes, of course. And there are tons of studies in many different fields, mostly with children, but we know structural functional imaging show different type of maturation, some type over or under connectivity, and you will see later, for instance, some response to sensory perception, for instance, are very different in an autistic person than a neurotypical. I will speak about history. You have the handouts, and this is recorded. So you forgive me if I go faster in the interest of time on certain slides, but I want to keep the history in this talk because it's very important. History helps us to understand facts that, you know, how the concept of autism, for instance, has evolved. You may learn a few facts here, and we're going to look at that together. So the DJ was here. DJ, do you see Eugen Bleuler here? Bleuler, of course, who coined the term autism, also schizophrenia and catatonia. And at the time, more than 100 years ago, it was characterized by social withdrawal, emotional coldness, and the predominance of inner life. That's important. It was an inner life. You will see that that concept may disappear 50 years later. Also, you may not have heard of these people here, because in general, we think of Asperger and Kanner when we speak of autism. Of course, autism has been there forever, has been observed by a good clinician forever, given different name. But particularly interesting was the work of Dr. Sukareva, who wrote beautiful, very empathetic and detailed clinical portraits of children already in 1925. And she was speaking about the girls. There were as many girls as young men in her description, things that got lost again for a while. In Austria, 10 years later, the psychiatrist George Frankl published very detailed observations, also a great clinician, and the lack of coordination for some children between facial expression, the body language, and speech. Where George Frankl in 1932, where he was working, suddenly came a new resident, trainee called Hans Asperger. And within a year, Hans Asperger will become the head of the department where George Frankl left to move to the US. He was Jewish. And to move to the US, he was helped by Leo Kanner, the one you've heard speaking about autism. What's interesting is that Frankl and Kanner have worked together, observed children together. Frankl submitted an article, but it's Kanner's article was published first. Of course, Kanner is the first man who created the Department of Child Psychiatry in the US. He wrote the first textbook in child psychiatry. He helped many of his colleague psychiatrists to emigrate from Europe. But so we heard of Leo Kanner as the one who discovered autism. He was helped probably a lot by the observations of Frankl. Asperger probably used Frankl observation too when he wrote his thesis that will be rediscovered in the 80s. And the reason why we don't speak about Asperger, we don't want to speak about Asperger today, is that certainly he was protecting some young autistic boy, thinking they could be useful for their age, but had not too much problem to send the feeble-minded and all the girls to the Spiegelbrand clinic in Vienna, where children were euthanized. Another important part of history, because it's still influencing the way people think in terms of autism, at least in France and a lot in West Europe, and place where psychoanalysis was important, is Bruno Bettelheim. Bruno Bettelheim also came in the US as an immigrant fleeing the Nazi. The problem was that Bettelheim lied when he spoke about his credential. He said he was a psychoanalyst. He was not. He said he was a doctor in psychology. He was not. He took 2 classes of psychology. But with this false credential, he became eventually professor at the University of Chicago. And from that pulpit, distributed and spoke about his theory that autism was due to a cold and distant mother that he called refrigerator mothers. He compared the mothers to SS in concentration camps. And he also explained that to protect themselves in ways from this mother, the child had to be in a fortress that was empty. You can imagine the devastating consequence of these false theories. And again, I speak about it today because many people still think of Bettelheim as a psychoanalyst and still have in mind what he said about autism. There were desperate times. I understand that many people wanted to try to help children, autistic children and their family. And among the people who tried to help them, we are at UCLA, at Harbor, was Eva Lovas, who also emigrated from Europe, was doctor in psychology, and in the 60s established a young autism project clinic at UCLA. A lot of us want to help, and in a way it was one of the first things, we can help your child. It didn't really speak about help the child to get better or cure from autism. He wanted to render the child undistinguishable from other children, which, we can question in some ways. He wanted to do that with gay people to a moment in his career. But to do that, he developed an intensive, at the time, violent behavioral methods, 40 hours a week or more, known as ABA, Applied Behavioral Analysis, and tried to use behavioral technique to change these children. Again, there are disparate times. I'm sure things are difficult, but I was really heartbroken and puzzled when I saw what Lovas would say in 1974 when speaking about the children. You have a person in the physical sense, you have hair, a nose, a mouth, but they are not people in the psychological sense. That's terrible. It's terrible because you suddenly feel that you're working with people, with children who are empty, who have no soul, who feel no pain, who are nobody. So today, many autistic activists with ABA when they were young consider it as torture, but some families also said that saved their children. It was extremely helpful at times. ABA is a multi-billion-dollar industry, and that's again can take a full other talk. Its practitioners say that things have changed, and things have changed certainly for many, but not necessarily with everybody. Some places are still using electric shock. And what is more concerning is that we have no multiple research, and here this one is the Department of Defense, who after long study have finding demonstrating that ABA is not working for its beneficiaries. So this is very concerning. And of course, this is also very distressing for parents who do not know then which type of therapy work, where to get it, and who will pay for that. This is a very complicated debate. So lesson from history, eugenic, of course, is scary. And when a lot of autistic activists are concerned when they why do you want to find a gene for autism exactly? Not sure there's one gene anyway, but this is concerning. Remind you the danger of myths and false theory. Remind you first, do not harm. Give all the people the benefit of the doubt and of humanity. Don't other them. They are us. And the consequences are so that many autistic now are asking to be at the table when it comes to research about them. Now, let's see how we can identify autistic people in your population. So as I told you, they're everywhere. Some without major intellectual disability, they work, they have families, and the range of symptoms can be very different, also depending on the timing of the environment, the age, the abilities, and the co-occurring conditions. The first thing you're going to look at is in terms of perception. Brain is, it's amazing. I discovered that researching for this talk, 11 million sensory impressions per second, and we are conscious about 40 or 50. I wouldn't be surprised though that autistic people may be conscious of more than that and takes a little longer to process them. But atypical sensory perceptions, all of them, sometimes hyper, sometimes hypo, is very characteristic of autism. And contrary to things that will change, you can learn to modulate the tone of your voice. You can learn to make eye contact. You can learn some social skills. The sensitivities will remain a lifelong characteristic for adults. So we'll go quickly through some. Again, each of them can require full grand rounds, but you are aware, I think, of the light, the problem, sensitivity to certain type of light, or the fascination for some type of light. But doing that, be okay. If someone will keep their sunglasses when they meet you for a consultation, that's fine. And that's not necessarily a sign of something weird. It's just that they don't tolerate the light or turn off the light. The processing is different. And I want to, some therapy I didn't mention today, where we're forcing children and mother to hold the kids in their arms and make eye contact for long minutes. When we speak about torture, we know that forcing eye contact led to increased amygdala activation. Amygdala is our emotional brain. That's activate when we are scared. That activate when we're a lot overwhelmed by emotion. So imagine how much some theory and some therapy, when we will help the person to look normal, can be very traumatic and detrimental. There's a very different variation in smell and taste that can, of course, affect feeding. And there's a lot of eating disorder that can be present when someone is autistic. Hypersensitivity to sound is extremely frequent. It's sometimes different for different sound. Again, and you see more and more young people going around being fine with their headphones on. I think that's important. Sensitivity to the tone of voice, children, but adults too. Think about that when you speak with them, in a stressful context in the emergency room. People can be very quickly interpret your voice as aggressive, even if it's not your intention. Another important sense system is the one who gives sense of balance, of movement, of our presence, the presence of our body in the world. Autistic people have often difficulties with that, difficulties that is expressed in problem in fine motor skills like writing, with pushing too much on the paper, difficulties with that, problem in posture and balance, difficulty stopping quickly or during an activity, a difficulty sometimes to evaluate the right distance when you are next to someone and bumping to the person. Interoception and nociception are very important in terms of knowing what's happening inside of us, perceiving the pain. And again, there's an atypical perception of pain. And some people may be close to peritonitis, to really severe medical problem, and not really feel it, or have alexithymia, not knowing how to communicate that pain, what's going on inside of them with the physician or the nurse. And again, if their face doesn't show it, their tone doesn't show it, their words don't show it, we have a high risk of missing something that is potentially dangerous. Hyper and hypersensitivity to touch, it's also well known. There are also a sense that we don't necessarily think about, like thermoception, ability to feel the temperature around you, and even sensitivity to barometric pressure. And I read in some study, at least, they've shown that during some important change in barometric pressure, our emergency room, psychiatric emergency room, tend to be more full. So what I just explained here show, you can see the result of that with the impression of clumsiness, and you certainly have seen that. There are different degrees in autistic children, autistic adult, a weird gait, a lack of fluency, problem with handwriting. That's why tablets have been really a life-saving for many children and adults. Difficulty to throw and kick a ball. So when you're already a little weird and different in the school, and you cannot participate to all those sports, that can increase also the risk to be bullied, the risk to be excluded. Certain sports, very important, don't seem to be affected. Swimming, trampoline, playing golf, and horseback riding. So that's important to know. And we'll speak later about catatonia and mutism. Of course, it involves motricity too. All right, still holding on. Perception, now let's look at cognition, right, in terms of how that's helping us to identify if someone has a autistic neurology. Remember the comparison earlier of people having different operating system, right? Some people work more as a Macintosh or Apple. Some people work more as Windows or a Linux system. So we all have different expression. Our cognitive system is using many different ways to work. And so we have attention, thought, perception, memory. We have executive functioning that mix together different processes. And each person is performing differently in many different fields. Now, something we've heard a lot about autism is the notion of a spectrum. The problem is spectrum is it's not really accurate when we speak about autism as relative to perception, as you heard what I described. Sometimes people perceive very much something and not at all something else, but also in terms of cognition. As you see, the better comparison is the switchboard that you see, the soundboard, and you imagine that with hundreds and hundreds of sliders. So each person has different settings. And when a neuropsychologist is testing a patient, one of the things they're trying to do is to try to identify these different settings. And what is interesting when you look at the results of some of these tests is that you have a very different type of profile when you look at a neurotypical person that you see here, the line which is almost straight, right? There's some difference in verbal skill and in working memory, but very minimal. While you look at the neurotypical, when you look at the autistic person, you have the spiky profile. Spiky profile is these mountains here. So you see someone who in terms of verbal skills is quite good, right? 120, but a terrible working memory, has excellent visual skills, can see something very well, but the processing speed is extremely slow. So autistic individuals show this form of asynchronous development, where you have some skills that are really well developed and others that are not. The spiky profile, I think, is a very good way to understand. It's a good way for the person to understand themselves, their strengths, and where they need more support. Give you an example here of a spiky profile of someone who has an IQ at the 98th percentile, but very more slow in processing speed, and ability to shift attention going from the 16th to the 91st percentile. You can see the difference in this. Executive functioning between the 98th percentile for a task and the 37th for another one. And an untimed task, which is almost perfect, 99th percentile. But if a different task is timed, you are not to the 11th, 16th percentile. This is telling you why accommodation can make such a difference for anybody at work, but in school. You can see someone who is smart, can get it, but will have time to bring back, to understand and share knowledge. So here are some characteristics of an autistic way of learning, problem solving. You've heard probably of that hyper-focus, but also a great difficulty to shift attention at time, enhanced pattern of recognition, a different way to solve problems, not always able to explain how they do it, which may be a problem for a 10-year-old or a 16-year-old can be accused of cheating while they actually really solve the problem, but think out of the box. Perfectionism. The bottom-up thinking is important. So autistic person generally work from the specifics, from the details, and go to the general idea. Or a neurotypical person in general work from the general idea and deduce things about the particular circumstances. Temple Grandin say it's an advantage for autistic because they have the freedom of not making assumption. And so we have a very good way to identify when people are bullshitting us, to take the terms of Temple Grandin, forgive my French. Different thing is the monotropism, special interest. So a mind who is focusing his attention on a small number of interests and may miss or ignoring things outside of that attention. Or that, of course, can be looked with its plus and cons. Something often used also to see if we speak of more on autistic neurology, if people who see the trees before the forest. So focus on the details versus the big picture, a little bit like the monotropism. It's been called in ableist language weak central coherence. Sometimes I suppose seeing the trees before the forest may have its advantages. Okay, memories. This is another very important place where you can make a difference when you try to make a diagnosis. So little reminding you about the different type of memories we have. You have the non-declarative implicit memories, right? Remembering things without remembering you remember. This non-conscious memories, many autistic people sometimes have very good one, some remarkable abilities, but there's generally no problem there. The declarative memory or conscious memory, so that's what you record and you can remember. That's more the hippocampus, prefrontal cortex. You have two categories. You have the semantic memory, which is remembering list of numbers, remembering poetry, remembering dates, remembering baseball as a result, right? That's the semantic memories. It's generally okay in autistic people, it's sometimes very good. Now, the problem when you're autistic is the episodic memories. So episodic memories involve the conscious recollection of experiences with the context in terms of time, in terms of place, in terms of the people who were there, in terms of associated emotions. That's the episodic memories. And as you can imagine, episodic memories are very important when we are building the narrative of our life, what we call autobiographic memory, right? Who am I? Where I'm coming from? What's my story? Well, if you have difficulties with episodic memories, which autistic people generally have, it affects the autobiographic memory and the construction of identity. And that's something we will see that can find in common sometime with women with borderline personality disorders. When you explore that, that's also why when you ask questions, when you interview an autistic person, it's not good to give open questions. They just don't know where you want to go. What are you talking about? So you want more precise questions, give some hints. And when you give prompts, the memory can come. They're not necessarily super precise, not necessarily the emotions linked to it, but memory can come. So that in terms of memory, very, very important. Oliver Sacks wrote a beautiful book. We interview many autistic people, including Temple Grandin. And he described the autistic narrative. He said there were strange discontinuities. People injected suddenly into the narrative, reference to incident, which the reader had no knowledge of, and suddenly change of topics. Not that Temple Grandins are so very high IQ, and some people are not autistic with very high IQ may also have tendency to think that we are reading their mind. Oliver Sacks compare this writing to Alice in Wonderland, and not a surprise, we think Lewis Carroll himself was autistic, most probably. Language. 30% at this time of autistic people are nonverbal. It's one of the signs in a child. A child doesn't speak or speak much, much later. No, not being verbal doesn't mean that you don't think, that you don't want to communicate, that you cannot communicate. And certainly people can communicate through multiple ways. And again, it's reminding how important it is to have hope and trust and see that things can change. So I don't know if you've met this young man, Jason Hardy. I heard of him just recently through social media. And Jason Hardy is British. And at 3 years old, he couldn't speak. And was, again, parents were told, not much I'm going to do. He's severely autistic, and that's what it is. Well, he couldn't speak until the age of 11. The parents kept him. A lot of people worked with him and supported him. He started speaking at 11, wrote and read at the age of 18. And last month, at 37 years old, he became the first Black professor and the youngest Black professor at the University of Cambridge in England in the field of sociology. So that the fact of not being nonverbal can also be temporary, and you may meet that particularly in stressful conditions like the ER, like a visit with you, like CL, when you have medical conditions. Some people who are very articulate suddenly are not able to communicate. It's very difficult if they don't have collaterals. Another way the language of autistic people has been qualified as being pedantic. Remember maybe the little professor that Asperger, that was how Asperger described some of these young patients. I don't like the word pedantic. I think it's kind of negative. If you have people who use very nice vocabulary and kids who very early use very nice vocabulary, you could call them smart or sophisticated. Anyway, you have a language also qualified as idiosyncratic, use of neologism very often, few emotion-laden words, misuse of pronouns, pay attention, particularly if it's someone whose English is the first language, impairment in semantic, loose association, focus on minor details, illogical thoughts, fusion of ideas and images that may appear as kind of a regressed thinking and writing. Well, if someone you are familiar with the way Carl Jung was speaking about James Joyce, he was using almost these last words. James Joyce, who also was autistic. The style is literal, so be attentive to that when you ask questions. Logical, very concrete, sometimes unusual association. Written instruction can really help very much, more than oral communication. So what is it to be autistic in a neurotypical world? Well, an environment can seem nice for you and pleasant with nice music, nice light, can be totally overwhelming for someone who is autistic. Also, it's well known, they don't do well with small talk. They don't follow conversation rules, have difficulties to know to initiate or to take turns or to end the conversation. They tend to be very concrete and honest, which can be interpreted as being rude, naive, without manners. Difficulties with certain sarcasm. That doesn't mean they don't have a sense of humor, don't always see if someone needs help, and have difficulties asking for help. But is this perspective from a lady who's on autistic not weird, as I'm autistic, which means everyone around me has a disorder that makes them say things they don't mean, not care about structure, fail to hyper-focus on a singular important topic, have an unreliable memories, drop weird hints, and creepily stare into my eyeball. So again, everything can be relative. I don't have the time to show, but please Google Anna Gatsby and the box. Go on Netflix. Anna Gatsby was diagnosed autistic in between her first and second special on Netflix. It's very funny, but it's also very educative about how the certain way of thinking can put you in a lot of troubles. Theory of mind is something you may have heard, as there were some of the theory trying to explain how the mind of autistic person function. The problem with the theory of mind, again, was that it was perceived as autistic people systematically lacking a theory of mind, being unable to understand that other people have a mind, what was in that mind and what is in their own mind. Well, multiple studies now have shown that it was kind of empirically questionable and certainly harmful to have a theory about how people function in that way. Clearly, autistic people may find harder to understand and express emotions, to read other people's emotions, in particular emotions in neurotypical. That does not mean that they don't or cannot empathize with others, and they cannot have a sense of what's happening for the others. It takes them longer to process social situation. And actually, for a long time, autistic people have been accused of not having empathy. Well, study showed that often they have too much empathy. Their amygdala is actually hyperactivated in multiple circumstances. So let's speak about empathy, because I think it's very, very important to clarify. It will be very important also for your the differential diagnosis. So empathy is complex. It's what you see, how you interpret it, how you feel it, how you respond. So there's a lot of phenomena in empathy. But you have certainly two different types of empathy. Cognitive empathy. That means you can intellectually or see, identify, interpret some cues, and you will understand the other person's feelings and predict how they react. And then you have the affective or emotional empathy, how we react to someone else, pain, emotional states, joy, and all that when we are aware of it. Well, it's clear now that the majority of autistic, because you have all kinds of autistic people, like all kinds of neurotypical people, so all kinds of personalities, but generally in autism, the emotional empathy is actually very, very important, sometimes overwhelming, but there are difficulties with the cognitive empathy. What's important, empathy also in autism is well known, extremely important and extended, not only towards animals, but sometimes towards objects. Now, it is important to remember that empathy is a two-way interactions. Like when we speak to people, we have kind of to speak a common language. If we speak languages that are too different and we don't learn the language of the other, there will be, of course, a lot of miscommunication. So Damian Milton, the autistic researcher himself, in 2012 wrote this very important theory called the double empathy problem. And what he suggests is that when people have different neurotype, autistic and non-autistic, but thinks of speaking different languages, there are some moments where they can click, they can understand, but there will be a lot of misunderstanding, we're not going to understand what's happening in the head of the other as very easily, but in both directions. Now, if people have similar neurotypes, it will be easier. So what it underlines is that it's not necessarily only the autistic person who cannot understand the neurotypical person. The neurotypical person themselves, when asked to identify emotions in autistic people, will do not as well as an autistic person identify as neurotypes. Hope I'm clear enough. A lot of data, but important. You can come back and look at the talk later. Let's speak now at one of the reasons why you may see the patient, in particular in the psychiatry, right? Problem with emotion regulations and behaviors. And Donna Williams, who was Temple Grandin, wrote a beautiful biography in the 80s about being autistic, explain right from the start, as you've seen in the historical perspective, the condition was judged from outside, empty fortress, and not from inside, according how it is experienced. That's what we're trying to do today. So in the unusual way to interact, to walk, to react can, of course, have sometimes devastating consequences in the street or in an inpatient unit when you interact with power and authority. In certain circumstances, provoking the person a fight, flight, or freeze response. Autistic people may react in ways that appear disproportionate, that are scary, and we will look into it. It's called sometimes meltdown or shutdown. But sometimes, of course, being different puts you in danger, even more if you are at the intersection of multiple difference. And so was the young man. I will show you a video. If this is a triggering video, it will be 1 minute. If you worry about watching something which is violent and triggering, turn off the sound and get off the computer for a minute. Thank you.
Stop right there. Stop. 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 I have a right to speak. No, I am an introvert. Please respect the boundaries that I am speaking. Stop. Stop. Relax. I'm going home. Relax, or I'm going to have to change this situation.
McLean is pinned to the ground and says this.
We have a use carotid. I'm just going home. I'm introvert. I'm different. Did you come out? He's out. Was he out? I heard you snoring. He didn't hear him completely. He didn't respond to this. It was actually Rose.
A few minutes after that encounter with the police, Elijah had lost his pulse. He was brain dead when he was brought to the hospital, and he died 2 days later. He was going in a store and walking around, not only being Black, but being autistic, having, hiding his face, and that was enough for the circumstances you saw after that. There have been so many Elijah in the past, yesterday, there are today, there will be more. But I hope that under watch, it will not happen in our clinics, in our emergency rooms, and that by you being the messengers and explaining more what's going on, when you work with autistic patients, we will have less of these horrible circumstances. So let's look at meltdown. So a meltdown is a form of nervous breakdown, which is often the result of situation or accumulation of situations, which create a high level of anxiety. The autistic person who is overstimulated may lose total control over the body in language. It's like in a fight or flight situation, it's really fight, an explosion. It can be self-harm, harm towards others. It is very scary. It's impossible to stop through words. And sometimes that's where medication and restraint are used, but that in itself can be re-traumatizing. Meltdowns are very physically tiring, emotionally draining, and can be replaced or followed by what we call shutdowns. So shutdowns is some autistic compared to a sleep mode on a computer. So lack of energy and ability to move, to do anything, sometimes can look or be catatonia. Again, the cause there can be sensory overload, emotional overload, change in routine, being rushed to make decision. Autistic shutdowns are not the same as tone warning. They don't do that to make your life difficult. What to do in the response? Oh, I'm sorry. I'm going to go back quickly. What to do in the response with a meltdown? Stay calm and reassuring. Think of your GPS. Remember the GPS, you can go in the wrong way, in the wrong place. They stay calm. They keep telling you to don't speak too much, avoid contact, avoid physical contact, avoid eye contact, give time, give a sanctuary. Very important. Sorry, I passed that. So in shutdown, what do we do for the autistic person? Try to find place, sleep, go slowly back to the world. For the entourage, give time and space, give them time to recover, understand why it came there. Don't try to push them. Don't try to do therapy at that time. You don't want to push them in a meltdown. The person is not able to communicate and answer at that time. These are where very serious disability appear. That's part of what's difficult. That's why we want to try to avoid by helping to avoid depression or autistic depression. For instance, I'm going to read you briefly an example of how things can go bad. And this is from a book called Unbroken by Alexis Quinn that I was very happy to meet in London in September last year. Alexis was a brilliant young woman. She represented England in the Olympics. She says she's a mother, a school teacher, an author. She's also autistic. And after the birth of her child and the tragic death of her brother, she lost it. She was depressed, accepted to be in psychiatry, and then got locked in. And basically the circumstances of her being inside the hospital and the way she was treated, unquote, would just have her meltdown after meltdown for which she was kept against her will. And you see that vicious circle. She literally escaped not only the hospital, left England, went to Africa for 2 years to escape that. She's now a big advocate. And here's in her biography, she described this that you can see in any of her words. I speak for Alexis. I'd only been on this ward a little when I had an incident with a nurse, talented, with whom I was getting along well. One day I said to Judy, I need to have my PRN medications. I could request that if I feel I needed them. I felt like that balloon in my head was about to burst. So I asked for the PRN. I needed the drug to stop overloads and meltdown. She said, yes, Alexi, you can have the PRN medication after the staff handover. I told, okay, I'm going to wait for that. The handover happened. The new staff came on the ward, but the nurse was too busy to give me the meds. I said to Judy, it's 3 o'clock. What time can I expect to have the medication? She told me I could have it in 5 minutes. So it would be 3:05. I said, I cannot have them at 3:05. I don't like fives. They're not a closed shape. I don't like odd numbers. Can I have them at 3:06? Yes, that's fine. It will be about then. Then it got to 3:06. And the nurse told me I could not have the medication because they were not ready. I was getting very frustrated. You need to let me have this medication because I need to go for a walk. Judy said, you cannot have a walk because there's no nurse to take you. I really want to use my leave because I had 7 consecutive days of good behavior. And I used to leave properly every time, not running away during my walk. I told her I'd been waiting the whole day. I just want my half hour. I want my 30 minutes a day. This is the time. I always have it every day. At this time, you need to let me out. She said, I cannot let you out. So I got very cross. The balloon in my head was getting too big. I could not understand why I could not have the PRN and why I could not have my leave. I didn't know why she was changing routine. I didn't know why the nurse was still in the office because she was supposed to be doing the medication now. I didn't ever want the medication, but I had to have it before my walk. I was by the exit door and I told her, you need to let me out of the door. Judy said, Lexi, I'm not going to let you out the door. I said, please, you need to let me out of the door, please. I was very polite because it's time. This is the time I have to go for my walk and I cannot be late. She grabbed me just above my wrist. I told her, get off, and pulled my arm away because the fire in my arm was agonizing. She fell back against the wall, tripped, had an asthma attack, and turned blue. The nurse was okay, but you can imagine the consequences of an incident like that. That's so easy to happen because we're all overworked, overwhelmed, not enough staff, but not being able to answer Alexi in time made much more work for everybody in addition to the trauma and the suffering of everybody. So when you have to identify autism in a patient, come for instance in the outpatient clinic, what are the hints you're going to use? Was there a lot of co-occurrences? As you see here, medical, epilepsy, of course, 25-30%, GI problems, autoimmune disease, Ehlers-Danlos syndrome, and POTS, these two medical problems very often associated with autism. So have your ear ringing when you hear that? All psychiatric problems can, of course, occur, but sleep problems are almost ubiquitous. Anxiety disorder, very important. ADHD, we'll see 30%, mood disorder. Basically, you have all the psychopathology that you can see. That's why it's so hard sometimes to disentangle situations. Look at the family history. People don't necessarily know they have an autistic father or mother, but if you look and listen well, you may find that. And many patients, after they had diagnosed, realize who it's coming from, in quotes. Anxiety, sleep problems are frequent, mood disorder frequent. Remember, the cause of death, the second one is suicide. Some risk increased, so you have increased risk of suicide. First, because we don't necessarily take seriously someone who speak of suicide on a monotone voice and don't show it on their face. The tendency to perseverate, the black and white thinking when the person feel entrapped, feel very stressed. A lot of camouflaging, increase the depression, increase the risk for suicide. There's a lot of non-suicidal self-injury. These are kind of a way to calm themselves for autistic people. Autistic burnout also associated with a high risk of suicide. As I said, multiple differential diagnoses and sometimes diagnoses you have both ADHD, 40% of adults, PTSD, 32 to 45% in autism versus 4.5%. Substance abuse and dependence, we don't have study yet showing that it would be a difference. But I suspect clinically, and I'm not the only one, of course, a lot of patients will use alcohol or marijuana at this time or other drug to be able to deal with the social anxiety of being in groups, being outside, or being at work. Very important, OCD. Autistic people have twice as likely to have an OCD diagnosis, and people with OCD 4 as much. So importance for the differential. Look at the early life. Was difficulty in social communication early in life or not? And very important, someone who's autistic, they love their rituals. They're egocentric. There's no problem with it. And they can also change rituals more easily than someone who has OCD. I spoke about the eating disorder earlier. Borderline personality disorder, this is one of the major diagnoses. So many autistic women were misdiagnosed with BPD. They have a lot in common, of course, difficulties in interpersonal relationships, self-harm, identity diffusion. But in a way, we should almost try to rule out autism before we give a diagnosis of borderline. Remember what I told you about empathy? That will be very useful for you when you try to make a diagnosis differential with narcissistic or antisocial. Both have a reduced affective empathy, opposite of an autistic person, but can have a very good cognitive empathy. Actually, antisocial personality disorders are generally very, very good and read cues and manipulate people emotionally. So they have very good cognitive empathy. And last but not least, schizophrenia. They've been linked for historical reasons. There are really not much connections. There are different types of speak and thinking. Of course, you want to look at the developmental history, which will be very important, very different. You want to see if the symptoms are short-term or long-term, what can cause certain symptoms, and be aware of the literality in autism. Of course, people if you ask them if they hear voice, and there are voice in the room next to you, but they will say probably they hear voices. So be careful. Catatonia, very important. Why do we need a diagnosis? I love this sentence. Why do you need a label? Because it's comfort to know that you are a normal zebra and not a strange horse. Because you cannot find a community with other zebras if you don't know you belong. And because it's impossible for a zebra to be happy or healthy spending its life feeling like a failed horse. That is saying it all. I think it's wonderfully said. So in general, when you share a late diagnosis, people are relieved to explain a lot of things in their life, a lot of the difficulties, sometimes a lot of the failures, a lot of things that were incomprehensible. But of course, it takes also time to deal with that discovery and face it, to share it with the family. Treatment, individual support group, medication like you would do with a patient in general, except, and it's a big, big exception, you have to be aware that autistic patients are generally very, very sensitive to medication. They may need dosage much lower than what you used to give to other patients. They're extremely sensitive to side effects. And the best way to be successful working with them is to believe them and work with them. Believe your patient. And remember, they are very, very sensitive. Hypersensitivity, right? All along with everything. All different medications that they can look, it's off-label since there's no treatment for autism, but you can treat what is associated. We're almost finished. I want to give you this information because we have so many patients who are so heavy DD or ADHD who are. So look at which medication does what. Know that you know that there is this hypersensitivity, there is this problem in executive functioning. So depends of what you want to do. You can use one stimulant more than other, or use multiple at a time if it's needed. Conclusion, think about our diagnosed autism in adults without intellectual disability, particularly women, minorities, older patients, multiple associated mental or physical health problem, multiple diagnosis, no treatment without much success, complaints about symptoms of medication that seem disproportionate, history of misunderstanding, difficult relationship with health professional. And very last, when you work with them, be aware of the physical environment. Remember how it's affecting you and them. Take your time, give the time to process to the patients, come back, leave the silence, let them process, hear what you say, help them. You don't have to make eye contact. We can turn off the light, make the patient comfortable. You have to be clear, simple, direct, avoid open-ended question, or you know why. Be aware they can be literal, make sure you understood. We should do that with all of patients, by the way, but even a little more with them. Do not take personally mutism, be flexible, give patients space, believe the autistic person. Thank you so much.